Thank you very much, and thank you very much for the last talk. It was inspirational. I'm probably not going to be particularly inspirational, but I am going to be challenging. I'd like to explain a little bit about Health Education England. Many of you are already interacting with us, and I'm very grateful for all the work that you do. But we only began in April, and I think you need to know that we are about supporting excellent healthcare. It's not just about educating this many doctors or that many nurses. It is all about the patient. We have to remember that through all of the very difficult discussions that we're going to go through about the allocation of resources. We are responsible not just for doctors, but for everybody in the healthcare system, so bands 1 to 4, undergraduates. Who's ever seen the NHS Careers Service? I certainly didn't know about it until I started this role. It wasn't something that applied to doctors, but it's hugely important if we're to get the brightest and the best of this country's children thinking about working for our health system. We have a distributed leadership model. We have 13 local education and training boards. I know some of you sit on those boards. We do have central offices in Leeds, London and Birmingham. But we work through the LETBs, and these are provider-dominated organisations, and we are directly accountable to the Secretary of State. Everyone talks about change, but I think what we're seeing now is an opportunity at professional level for major change. And I would hope that if we work together, we can deliver some of the changes through education that will benefit patients. But there are some politics to this. We are Health Education England, and we are part of the United Kingdom, and there are 4 different systems, different in terms of what they do for health, different in terms of what they do for commissioning education. And we have to be aware that decisions that I might want to make with Health Education England colleagues have an impact, and vice versa. The new system of commissioning of care is challenging, because we have to relate to each other, we have to talk to each other, we have to communicate. I know that's radical, but we do have to try and make it work better. We cannot go on having silos of commissioning. And I would put it to you that education for doctors has been in a silo well away from what patients actually need for far too long. I think there is, and I hope it will continue to be, a very positive move to integrating health and social care. It's long overdue, but the last talk and Angela's talk were all about what patients need and what the public expects. We can't go on working in silos, but again, further integration means further reorganisation, and we're not yet 6 months old. I do think there's a new relationship emerging between the public and doctors and patients and their doctors. And I would value that, but I think the patients expect high quality. Nobody expects to be treated badly. Nobody wants bad outcomes. And we have to fulfill those expectations through a different way of educating and training. There are major changes in the demography of the workforce. We will retire later, and you will all be women. We need to understand what that means. I'm fed up with the term feminisation of the workforce as if it's some sort of problem. And I understand the new term is genderisation, which isn't much better. Personally, I don't see this as a problem. I see this as a huge opportunity. As an obstetrician and gynaecologist, I understand that pregnancy lasts around 9 months. It's taken me many years to get to that knowledge. We should be able to plan for a workforce that embraces women who have families, and women who don't have families, and men who also want to spend more time with their families. It is a nonsense that we can't do workforce planning more effectively. Okay, well, I'll stop there. But of course, the context that we all work in is the context of appalling care. And these are just some of the hospitals and places where we see care that's been unacceptable. Everyone talks about it. We have an opportunity to do something about it. This is the word cloud from the Francis report. And if you look on the far right, the top 5 phrases are exactly what we want to see in Health Education England. There is nothing different. But we can't go on having report after report, task force, working group, whatever it might be, and not actually do anything. The worst thing we can do is commission another group of people to sit in a room and think. We actually have to do something. So this is the distribution of the local education and training boards. We have 13 and we have 15 postgraduate deans for geographical reasons. They are committees of health education England. They are statutory committees of us, so they're not autonomous, but our leadership is distributed across them. They have a managing director equivalent to a chief executive, an independent chair, a director of education and quality, and a head of finance. All the deanery functions that you're familiar with are now part of these LETBs. That's our budget, so I'm costing you just under £10,000 a minute. What's interesting is the approximation of the cost to train various healthcare professionals. This money is now, for the first time ever, in one big pot. And we are going to have to think carefully about how we distribute these funds in the future. So where have we got to? Well, we've appointed nearly everyone that's supposed to work for us. We have a board and governing bodies set up. Our bases around the country are functional, just about. And we have delivered something called authorisation. So each of the local education training boards had to go through a very rigorous authorisation process, which included us asking, how are you going to interact with the community? How are you going to hear the voice of primary care? We have responded to the Francis inquiry, and we've received our mandate, which I'll talk a little bit about now. And last week, we received the first ever attempt at integrated workforce plans from the local education and training boards. By December, we are tasked with producing the first ever integrated English NHS workforce plan. No one's ever done this. No one's ever said, if you have this many of that, how many of those do you have? It won't be pretty, and it won't be right, but it is a step in the right direction. So we sit in this interesting mix. We have clear government priorities, we have local priorities, and we have national priorities. If we get it right, that bit in the middle will work. But those tensions are what we will exploit in order to get the best for patients. Workforce planning, well, many of you here have been involved in workforce planning, and we've tried to conceptualize it as a balance. We want it underpinned by quality, and we need to understand both the demand and the supply side. And it isn't easy. For all of us involved in medical workforce planning, it has always been reduced down to so how many are we going to recruit this year? That really isn't sophisticated enough. And this model will attempt to actually start to look at some of the pressures, and I'll talk a bit about them in relation to your specialty. So we got the mandate in May, which is slightly later than we'd expected, and it's being refreshed in November. So it's an extraordinary living document, I think, and our feet are held to the fire over delivering some of it. These are some of the pressures in the mandate, and I'm going to pick out the ones that I think are most pertinent to you, but I would also ask you to look down in the middle at the one that says dementia training. We were asked to produce a dementia training strategy for 100,000 healthcare workers this year. We need your help, and I'm aware that this has gone out to CCGs, but we're very keen to hear from general practice about how many foundation level training, so very low level training, your staff have been put through, and you will all be asked to do that. We're writing to the Royal College this week to ask us some help understanding this. However, the big issues for you are GP training, the expansion of that, and the short-term deliverable, so that at least 50% of undergraduates consider becoming GPs. And we have to report on that, and we have to have made progress towards that relatively soon. How we get young people to choose general practice is not, I would suggest, by closing down training in all of the surgical specialties, although it's a tool that we will be employing to a certain extent. It is about ensuring that medical schools understand their responsibility. Their responsibility is not just to produce the research doctors of tomorrow, not just to provide a number of people doing X at laboratory level, but to actually look at what the public need. And we need to have a different dialogue with our colleagues in undergraduate world about what our expectations are of those young people. It seems to me that that starts right at the very point of selection into medical school. If your selection is done by interview and the only people interviewing hold chairs of academic molecular biology, genetics, obstetrics and gynecology, you are probably not going to see selection of people who have the values and behaviours necessary to work in the very difficult primary care environment. So we need to have a conversation, and indeed are, about what are the values of youngsters going into medical school, and how will those values be matched against the expectation that we need at least half of them to go into a primary care focused career. GP extension. The mandate doesn't actually say a fourth year. It says that we will enhance GP training. The focus of that is around child health and mental health, and I would absolutely go back and rewrite that as managing difficult families. It's an opportunity, but it is also not fully panned out in our world. This is a piece of work done by the Centre for Workforce Intelligence, which is actually a good piece of work. And it does tell us about the need for more GPs. But the context of both of these mandate requirements are that there is a review of primary care being done by NHS England and Monitor. We do see the need for a radical redesign of the current model of general practice emerging from these discussions. We do need to develop the wider primary care workforce, and there needs to be a community infrastructure. I'm struggling with the concept that the community excludes the hospital. That cannot be right. We have to break down walls, not just put them somewhere else. And care in the community is clearly not exclusively delivered by GPs, and we need to understand that before we can pour resources into one part of the framework. This is an analysis of GPs in the population, and it won't surprise you to know that where those red blobs are also where we find it difficult to get trainees to go, and indeed to have enough training capacity. So we may find that we expand the number of GPs, but in all the wrong areas, and it won't actually make an impact. How do we incentivize people to not only work, but also train in parts of the country that so far they aren't working in? So this is some data from my colleague Simon Plint, who's part of the task force on this. And I think what interested me most was the 20% of women who leave the GP workforce under the age of 34. So what on earth is happening? We need these women to work. We need this resource. How are we making the job so unattractive that we're not keeping bright young people in it? What can we do to be flexible enough to change the way in which people want to work? We can't afford to lose anyone. So our proposals from the task force, which is a 4-country group that started before HEE came on board, and their recommendations are likely to be an increase in numbers, up to 3,250 in 2015. That's training places. And they want this balanced by a corresponding decrease in specialty numbers, which is going to be an interesting discussion. That decrease will not fund this, okay? It's not just about resources, it's about making people make different career decisions. All of the evidence suggests that that's way too late in the system to do that. Once they've done their foundation years, an awful lot of them know what they're going to do. And you can't force someone who went to medical school wanting to be a neurosurgeon into general practice at that stage and expect good outcomes for patients. So we need to think about this. And this task force is reporting in December. And HEE will receive this report, and we will have to look at what we can and will implement. But just to show you that we are on a trajectory to try and increase numbers. If you look at the red figure in the middle, that is this year's recruitment vacancies, so 2,814. We were hoping to be at 3,050 this year. And the reason that we're not is that those places have not been found in the old deaneries and now in the Letbys. We cannot expand beyond what is available out there. Some of it is funding, some of it is actually the resource in terms of space, time, and trainers. If we look at the enhanced GP training, it's very difficult to say that the people that you're producing now aren't good, because they are, I've met them. But there is something about enhancing skills, perhaps thinking differently, and I would like to think very radically about what the next generation need. And we recognise that if we shift any work from primary care into secondary care will be overwhelmed and the whole system will collapse. So there is a recognition we need to do something, but how we do it is the challenge. We've asked our local education training boards to look at the models and look at the affordability. Where's the unmatched need in community services? What are they doing in terms of developing integrated services locally? Can there be some flexibility with providing out-of-hours capacity? So our local education training boards are talking to people and they are exploring the options, and we are expecting reports from all 13 of them by the end of this month. So these are the questions we're asking the whole system. Are you persuaded that GP numbers need to be expanded? How would you manage the impact on secondary care service delivery, because we do not work in silos? And what's the greater priority for this year's investment plan, GP expansion or GP extension? And it may not be an either or, but it certainly is a question we need to ask. And can we use the extension to change the way in which primary care is delivered? And what do we need to do in Health Education England to shift care out of secondary hospitals into the community? And I would add to that, we need a really helpful working definition, patch by patch, of what the community really looks like. So we have huge ambition for the future. This is the first time that all budgets, from undergraduate through to postgraduate and CPD, have been under one roof. We are going to be challenged by the tariff, the levy. Are we going to put a price on a trainee's head that follows round? How are we going to distribute funds geographically? London traditionally has had greater weighting in terms of the SIFT money, undergraduate funding, than elsewhere in the country. That's an interesting discussion, I can assure you. So there's a whole lot of organisational things that can help unlock opportunity. But we have to take them, because we want a workforce that's educated and trained to be flexible and responsive, but whose primary responsibility is to raise the quality of patient care. So our measures will be about that. Improvements in safety, improvements in patient experience and trainees' experience, improvements in clinical outcomes, and the spread of innovation. We are very committed to thinking through the system, but we have limited time. We have picked up everything that's been done before. We've appointed nurses, doctors, allied healthcare professionals, but we want to think differently. So please engage with your local education training boards. Please ensure that your CCGs are engaged with them, and let us know where you see the gaps in the system and how you see us answering some of the challenges in our mandate. Thank you very much.